Hi, good evening, everyone, and welcome to our webinar this evening with our wonderful partners, HOAG, who has been with us for about 3 years now. I briefly want to introduce Dr. Sina Safahieh from HOAG's Aspire program, Prerna Rao, also from HOAG's Aspire program, Superintendent Kirsten Vital-Brulti, who oversees our Capistrano Unified School District, and Jimmy Knodel, who is our team member here in communications. So briefly, Superintendent Vital, I would like you to welcome everyone here tonight.
So welcome all of you here this evening. I just want to begin by just saying I'm grateful for our HOAG partnership. Really appreciate Dr. Sina Safahieh and Prerna Rao. This is the third year that the team at HOAG has partnered with our school district to raise awareness of teen mental health and substance abuse, and to assist our families with these very challenging subjects. This has been an unbelievable time for us as a school district and as a community, and I know there's a lot of anxiety and grief and a sense of loss as we move towards the last day of this school year. So much to celebrate, and yet so much that I know students can also be so stressed about. Students are feeling all of this, and so are the adults. And so important that we can come together to support our students and each other as we work through this and prepare for the end of the 21-22 school year. And now I'll turn it over to Dr. Sina.
And Dr. Cena has a packed presentation tonight. We'll focus on substance abuse, and we will take some time, about 15 minutes approximately at the end, for Q&A. So Dr. Cena, it is all yours. Thank you.
Thank you so much. Appreciate the introductions. It's a pleasure to be here as always. And we love this collaboration with all the school districts, but especially Capistrano, because you guys have taken the bull by the horns and have taken mental health very seriously, which in this time of need, which is very appropriate. So we're happy to be here. I'm going to switch over to my presentation now. Oops. Sorry. Let's go back. 1 second here. Share screen. Okay. Sorry about that. All right, so this presentation is entitled Substance Use, Vaping, and the Impact on Teens. Substance abuse has been an issue with the human population for millennia, although I would say more recently there's been an increase in self-medication just because of all the impact that we've all endured during this COVID pandemic. We're going to talk about different statistics prior to COVID and delve into a little bit about COVID as well. But I'm glad to present this because it's a very important topic that I think parents and kids themselves need to be aware of. And information is power, and the more information parents and kids have themselves, the more they can do something about preventing some of these substance abuse issues or substance dependence issues even from becoming a major problem to begin with. My background, real briefly, I'm a double board certified child, adolescent, and adult psychiatrist. I went to UTMB medical branch. That's medical school in Texas. I'm originally from Texas, and I did my adult psychiatric residency and child fellowship training at UC Irvine. I have a private practice in Newport Beach, and I'm on staff at HOAG and HOAG. I'm medical director of the Aspire programs for about 6 years now in Newport and Irvine HOAG hospitals. And I'm one of the team doctors for the LA Chargers and a major league baseball doctor as well. So jumping right in, the reason why we're even bringing this topic up, especially in this adolescent population, is because 9 out of 10 people with substance abuse problems started using before the age of 18. And so if you can nip these issues in the bud before that or even prevent it from occurring, then hopefully it won't be a lifelong issue like it can be for a huge majority of people that do go down this path. By senior year, 70% of high school students will have tried alcohol, 50% will have taken an illegal drug, 40% will have smoked a cigarette. Now we can switch that to vaping. Vaping's actually increased, meaning there's more nicotine usage now than there was prior to the onset of ecigs and vapes and whatnot. So nicotine usage has gone up, although cigarettes have gone down, and we'll talk about that in a few. And over 20% have used a prescription drug for non-medical purposes, either getting from a friend or a family member or off the streets potentially. Using drugs before the age of 18 increases the risk of substance use disorders by 6.5 times, meaning 650% increase, not just 6.5%. It's a huge increase. It's astronomical. And unfortunately, 10% of adolescents receive treatment. I was going to mention this too. I speak really quickly, unfortunately, and then beyond that, we have a lot of slides to go through. So if I speak too quickly, what I can do is send this presentation in in a PDF format to whichever parents are asking for it. So that's not a problem. Does development matter? It definitely does. You can see here in this chart, blue is kids younger than 14 years old, orange is 5 to 17 years old, and yellow is greater than 17 years old. And you can see that lifetime tobacco users, the earlier these kids start using, whether it's tobacco, alcohol, or marijuana, the much higher chance there that they're going to have potentially lifetime dependency on these substances. I brought up nicotine earlier. The average cigarette contains about 10 to 12 milligrams of nicotine. You don't inhale every milligram as you burn nicotine. So when you're using a cigarette, you're getting about anywhere from 1.1 to 1.8 milligrams of nicotine. That means for about the typical pack of cigarettes is 20 cigarettes. And so you're inhaling between 22 to 36 milligrams of nicotine. That's going to be very different than kids typically and young adults who are using these vape pens, because they're using these things throughout the day, and they're really easy to conceal because there isn't that noxious smell compared to cigarettes. And so because of the way they can hide these things and how easy they are to use, there's a much higher concentration per day of nicotine going to these kids' system. And so you can see here a cigar is anywhere from like 13.3 to 15.4 milligrams, e-cigs, 15 puffs, meaning like each puff can be equivalent to a milligram, to a half milligram to 1 milligram, which is significant compared to cigarettes. And then tobacco pipe, anywhere from 30 to 50 milligrams, chewing tobacco, an entire can is about 144 milligrams, and hookah is about 1 milligram per puff as well. This is what I was referring to earlier. You can see here, cigarettes are in the yellow, e-cigarettes are in the pink. And you can see how from 2011 to 2019, significant decrease in cigarette usage, but unfortunately a much higher and actually a total percentage higher of e-cigarette usage. You can see here in 2011, about 15% of kids or teens were using cigarettes compared to about 1% of e-cigs. Now you have a total of almost, seems here like 27% of kids using e-vapes, which means that overall there's about a 10% increase in nicotine usage. And we're going to talk about how nicotine can be detrimental to especially to a young developing brain. Let alone the other toxic issues that can cause physically with your lungs and other organs as well, or other organ systems too. What do teens say is in their e-cigs? Thankfully, 13%, which is unfortunate because that's not a majority at all. They know that there's nicotine in the e-vapes. Most of these e-cigs do have nicotine, a large majority. I'd say after that, the second most common substance in these e-cigs now is marijuana. Unfortunately, over 2/3 thought that it was only flavoring, when that's not the case. Most of these e-cigs do have nicotine, which, by the way, is one of the most addictive substances on the planet, meaning it's up there with crack cocaine and heroin. Like it's a really hard substance to quit, but I'm sure some people in the audience today have hopefully successfully been able to get off nicotine, but it can be a doozy. And we're going to talk about different ways to wean off nicotine towards the end of this presentation. I like this slide because it discusses the different types of marijuana. Unfortunately, a lot of doctors and other clinicians, including parents themselves, and even some of these kids don't even know what these things are. So you can see like there's marijuana flower, then there's edibles, then there's synthetic marijuana, which is highly toxic and dangerous. The reason why is because we're talking about 1,000 times of binding affinity on a cannabinoid receptor, meaning that compared to regular normal marijuana, K2 or spice or the synthetic marijuanas, they latch onto that cannabinoid receptor and they don't let go. And unfortunately, kids and adults have died using these substances, the synthetic weed. So not that I want kids to use marijuana, but I'd much rather them use regular marijuana than anything synthetic. And nowadays, there's some kids coming to me asking about THC Delta 8 and then Delta 10. These things are not tested in any way whatsoever. In theory, they are going to be safer than Delta 9 normal THC. but the studies aren't out there. And I advise parents and kids, like, you don't want to, because those drugs, a lot of times the Delta 8 and Delta 10 tend to be synthetic as well, at least the way they're derived. And that can be potentially really dangerous too. You can see here the concentrates that unfortunately some of these distillates can be actually be liquefied into these little cartridges. And so you can see here we have shatter, we have butter, crumble, sauce, distillate, hashes, maybe 70 times more potent than regular THC. And that's still not equivalent to like these newer THC ecigs that have up to sometimes 95+% THC. The most potent marijuana on the planet is about 35%, meaning flower. And that's with all different types of genetic testing and over years being able to like purify these types of plants. The concentrates are significantly more are higher in concentration and in turn can be way more dangerous as well. The other thing I didn't bring up is now they have marijuana in basically anything, not just edibles, but drinks and tinctures as well, different types of pills. And so now that it's become legal in a lot of states, it's available. And that makes it particularly dangerous because kids, unfortunately, in our society, when we think about things that are legal, they don't seem as detrimental, but they are. Like alcohol is the worst drug on the planet by far. There's nothing even close. 2/3 of all assaults, whether it's physical, sexual, whether we're talking about murder, just violence in general, 2/3 of those types of situations are directly related to alcohol. And that is a legal substance. So just because something is legal doesn't mean that it's appropriate, especially for young people to use. Like I brought up earlier, the concentrates can be up to 90%, flowers up to about 35%. You can see here it goes to the different types of modalities, including the tinctures, the capsules, cartridges, hash, and what are called dabs. I have a quick example of a kid who was using so much dab. A dab is like highly concentrated THC that they were using with a water pipe to smoke. And this kid had used it so much that it actually ended up crystallizing and like basically adhering to the walls of his nasal cavities. And this kid couldn't breathe. Like we actually sent him to an ENT. They basically rooted his nasal cavity to open up all that concentrate that had plastered itself to his nasal cavities. So you can just imagine that like what's happening in his brain, what's happening in his lungs, let alone his nasal cavities. But thankfully he was okay and learned his lesson. What I brought up is exemplified in this chart, which is perceived, when there's decreased perceived risk, there's increased use. So you can see here in the last 10, 20 years, there's been a decreased perceived risk of marijuana, and that's correlated with a direct increase in marijuana use. And that's unfortunate because I've had several patients that have actually become psychotic, and some of them have actually become permanently schizophrenic from using marijuana. The studies show we're talking about anywhere from 400% plus increased risk of psychosis for kids who use marijuana and young adults up until the age of about 24, 25, when the brain starts formalizing its development. And this segues into the next slide. Not only is it psychosis risk that we're going to talk about, I believe, in the next slide, but it also can affect IQ and cognitive impairment. Some kids in this presentation, if there's any in the audience or parents, you probably know some friends yourselves that are growing up or these days that they kind of perma-fried their brains when they were younger, like in middle school, high school, even like in college, used too much marijuana, used too many substances, and that directly impacted their brain development and their cognition, their processing, and including things like emotional regulation. So you can see here, this gets into like the nitty gritty of a specific study that showed that there was an IQ drop for people who were using regularly versus were dependent on it. What I brought up earlier, this is a study out of Germany, about 2,000 kids, that they showed over time there was an increased risk in psychosis with kids that used THC. And these days, because of the vape pens, because of that, what I brought up earlier, up to 90+% THC concentration, there's been an increased risk of psychosis in this country because of these vape pens, and that's unfortunate. At least for some families and some kids, it's life-changing in a really negative way. It's really heartbreaking as a doctor to see a child, imagine as a parent, watching your child become more and more psychotic, detached from reality over time that could have been potentially preventable. You can see here, it's not just psychosis that I'm worried about, and parents shouldn't be worried about either, including kids themselves. much increased risk of mood disorders, anxiety disorders, depressive disorders, even bipolar disorder, meaning going into manic episodes, panic disorders, social phobia, specific phobia, generalized anxiety, meaning it affects mood disorders and anxiety disorders directly. How does it work and how do addictions work in general? This isn't just for marijuana or alcohol or other substances, including nicotine. It's also related to things like other addictions, including tech addiction, social media addiction, video game addiction, sex addiction, gambling, so on and so forth. These all go to the same brain center or same brain pathways they're activated by the brain's pleasure circuit called the nucleus accumbens, and as well as the amygdala, that's the emotional center of the brain, and the orbitofrontal cortex. PET scans that we use to like test for like metastasis or like spread of cancer have revealed, like when you do that in the brain, you can use PET scans in different ways. They've revealed that the dopamine that's released in the nucleus accumbens and what's called the dorsal striatum, these are different parts of the brain that are responsible for this addiction reward pathway that is reinforced over time the more and more you use a particular agent. I joke sometimes with, at least in some of these presentations, although it's not that funny, I ask parents like, what is this? Because it just looks like someone's like, for whatever reason, inhaling something out of their hoodie. And this is actually a vaping hoodie where you can have drawstring used as a vaping device. And so it's another, I would say, stealthy way, a nefarious way of getting nicotine and or marijuana into your system at any time, like anywhere, anytime, including like in the classroom. I have multiple kids that will openly volunteer that they vape in class and that they're able to hide it because they just become really adjusted to not coughing and that they can conceal the vapor itself too. Unfortunately, there's other types of these vapes that look like pencils, like pens, like markers, USB drive, and even watches that are actual vape pens. So the market is ripe to manipulate. E-cigarettes are battery operated devices. They typically heat liquid that contains nicotine or marijuana, create vapor that is inhaled, and enter the US market in 2006. Why are vaporizers perfect for teens? Because it's technology on a stick. It's a perfect fit for the smartphone generation. They're small, they're rechargeable, they're easy to use, they're easy to modify. Some of the kids love the way they taste and smell. It gives kids some access to trying new things. And they just crave their independence when they do these things as well. And there's up to, at least at one point before the government started regulating, there were up to 15,000 flavors. And so because you can modify the puff volume and the liquids and the power in the vape, and then the temperature of the device itself, there's a lot of ways that these kids can modify their experience. At least up until the government took away these flavored e-cigs, the most common flavor was mint, and second was mango and fruit. You can see like classic tobacco is literally the lowest, and that's because it doesn't have that flavor that was, in my opinion, designed to lure young people. I want to remind people that aerosols are not the same as vapor. Vapor is literally defined as it has to be derived from water. So this is not vapor. It's an actual aerosol, meaning it's a finely suspended particle of liquid and gas that's created. And unfortunately, some of these substances were not meant to be vaped. Like what? Like propylene glycol, you could eat that. It's in a lot of different substances. Excuse me, it's a lot of different products, but it's not safe to inhale. Different alcohols are not supposed to be inhaled. Different metallic particles like chromium, cadmium, lead, tin, nickel, manganese, arsenic. These things are all toxic and should not be inhaled. And some of these metals are like microparticles coming off the heating coil. So even if the cartridge itself is purified and lab tests and whatnot, it's the actual metallic particles coming off that coil that's heating up the cartridge that's leading to potentially increased risk of cancer and other lung issues as well. As I brought up earlier, some of these toxicants, the propylene glycol, diacetyl, these are all flavors that are actually toxic. Like cinnamaldehyde is cinnamon, benzaldehyde is cherry. People who only use e-cigarettes increase their risk of developing lung cancer by about 30%, which is extremely significant. And then people who people who use these substances have an increased risk of developing chronic bronchitis, emphysema, asthma, or COPD. And those who are the highest risk were those who both use cigarettes and vape pens. I wanted to remind everyone that nicotine addiction is definitely a pediatric disease. I presented something similar to this presentation to the HOAG medical group prior to COVID, and they were shocked, like they were astonished in a lot of ways because they didn't, like for instance, that whole slide I had on marijuana, they weren't even aware of some of the different names. And as a physician, especially as a pediatric specialist, you need to be in tune with the different names and different modalities that kids are using these things if you want to approach them in a non-judgmental way and just try to extract information. And so in this situation, kids, parents, clinicians, teachers, counselors, they all need to realize that teen brains are much more sensitive to nicotine and much more vulnerable to addiction. I have a lot of parents who are like anti-drug, but they're okay with nicotine for whatever reason, because it's perceived as not as dangerous. And in some ways, I would say, would I rather have a kid use nicotine or marijuana? I'd rather have them use nicotine. So that's not out of left field, because the long-term consequences are not as dangerous, but that doesn't mean it's not dangerous and it's not consequential. And so the way these kids have gotten hooked with these substances, or there's like, especially when Juul first came out, they developed not just a really, you could say, novel way of getting these vape into your system, or these aerosols in your system, but they also made new versions of nicotine salts that are smoother and easier to use, meaning less coughing, less irritation, means increased use. And it doesn't only affect the brain. There's nicotinic receptors all over your body. And so this can lead to hyperactivity. It can lead, as a neurotoxin, it can lead to different things like learning issues, memory issues, attention issues, even like somatic anxiety, meaning like body anxiety. In extreme cases, you could technically OD on nicotine if you just take it on a horrific level. And so there are some extreme cases where kids and adults have developed seizures, gone into comas, and even had respiratory failure. Unfortunately, I really like this picture right here, because it says tobacco industry as a kids menu, and it's true. The government is trying to squash that, but there are different loopholes that we'll talk about in a second, where these companies are able to still get these flavored e-vapes into kids systems. About 3,000 teenagers start smoking every day. A third of them will die prematurely of a smoking related disease. Most likely, these kids are more likely to take other risks too, like not wearing seatbelts, getting into fights, carrying weapons, having sex at a younger age. And kids who do use nicotine are more likely to use marijuana and alcohol, as well as other drugs as a gateway drug. Kids who do use nicotine do have a higher chance of having anxiety and depression. Epigenetic changes means that your DNA literally changes. And then that means that you could increase the risk of addiction for your children if you're using as a teenager yourself, like meaning decades later, it can impact, or even generations later, it can impact your family, which is why we ask about addiction, especially like in our setting as clinicians, we always ask about addiction in the family, because it's a precursor, and there's a chance the child has an increased risk of having addiction if a primary parent or a sibling does as well. And ultimately, it's like, what do smokers really need? Adult smokers, do they really need 15,000 different flavors to quit nicotine? They do not. These substances, these flavors were intentionally designed to get kids hooked, and that's a fact, at least in my opinion. This goes back a few years, but in 2017, 2018, there was a big study, California Healthy Kids Survey, and I'll go through each district really quickly, but this was for Irvine Unified School District. Yellow is 7th grade, green is 9th grade, and 11th grade is in the blue. And you can see how these rates go up dramatically in the span of only a few years, especially when we're talking about alcohol use and marijuana use as well. For current e-cig use, you can see in 9th grade, Irvine USD was 4%, Newport Mesa was 11%, Capistrano was 10%, and Tustin was 10%. You can see by 11th grade, some of these rates doubled, like from 4 to 9, Newport Mesa 11 to 19, Capistrano almost doubled from 10 to almost 20%, and Tustin, for whatever reason, stayed about the same. But for the most part, we see almost a double increase usage, which again, in science, 5% increase is considered significant. We're talking about almost 100% increase. So there's no doubt that the usage goes up as these kids get a little bit older. Back when, you guys probably heard of this term, it's called EVALI, which stands for e-cigarette or vaping product use associated lung injury. The CDC defined this when there were several kids and adults who died using e-vapes, and that's because what they found out later was vitamin E acetate, which is an additive in some of these vape pens that was causing significant issues. Like what? Like we're talking about 95% of people with EVALI develop respiratory symptoms, and 77% actually had GI issues as well. Sometimes you have to go get steroids. Hospitalizations occurred as well, and unfortunately, people did die too. And then because your lungs are weaker in that situation, they're more vulnerable to infections like pneumonia. And speaking of pneumonia, there's different types of flavors you can get. I'm not going to read all the little details here, but it's like hypersensitivity pneumonia or alveolar damage. Alveoli is like the little bubbles, the little air sacs in your lungs. Those get damaged. You can have hemorrhaging of the lungs, so on and so forth, including different types of pneumonia. So it can be something that can be really, really dangerous and potentially affect your breathing for life, where some of these patients have to go on breathing machines and ended up on long-term oxygen treatment as well. As I brought up earlier, vitamin E oil was strongly linked to that. Back in January 2020, there were like at least 2,800 hospitalized cases, 60 deaths up until that point. That went up, but thankfully, because of some of the spotlighting of this issue, there is more lab testing happening to make sure that vitamin E acetate isn't in any of these products. It's not just the actual concentrate that's dangerous. It's some of these batteries, especially the ones that, let's say they're coming from China and from other countries where they're not, or like let's say you get some of these things off Amazon, for instance, that aren't tried and true brands. They're going to have a higher likelihood of exploding. Like anytime you have a lithium or any kind of battery, there's a chance it could explode. And when you're putting this up to your mouth, you can see this poor individual here, like how that blew up in his face. There have been people who died as well when these batteries exploded. And you can imagine your vape pen's working fine. You drop it on the ground, it short circuits. The next time you hit it again, explosion. I mean, these things do happen. And the reason I even know about this is because I had a friend who was an attorney who was in a class action lawsuit about different individuals, including different males and females who like they had kept the vape pens in their pockets, and at least one or several cases where like genitalia was damaged, and like, and we're talking about really dangerous situations that are catastrophic and life-changing. Now, does this happen all the time? Obviously it doesn't, but these are potential risks that you don't worry about until it unfortunately happens. Back to increasing nicotine concentration and how that correlates to physiologic dependence. The higher the nicotine concentrates are, at least in America where they weren't regulated, we were talking about at least these substances, these vape pens had 4%, at least 4% nicotine that was comprised about 3/4 of the market. In Europe, they weren't allowed to have anything above 2%. And so, like I mentioned earlier about Juul, the way they developed the nicotine, the way it was distributed in your system, it's absorbed up to 2.7 times faster than other brands. And anecdotally, that causes major issues for these kids, meaning they become severely dependent. They can't concentrate in class. They're actually having to wake up in the middle of the night to quell their withdrawal because they're on so much nicotine that they're having withdrawals in the middle of the night, and it's waking them up because they're having cravings. So that gives you an idea of how dangerous and how severe things can get. The government did lay out some laws, and some of these laws were passed, but unfortunately, there's still some exceptions. Like for instance, in this one policy they had, there was a little footnote that said that all flavors were still permitted if they were in devices that cannot be refilled and were designed to be dispensed. And that's when different companies like Puff Bars and Blue, Posh, and Stig, they're all pre-charged, pre-filled devices that once the liquid runs out, you just throw it out. And so like these quotes are from a New York Times article where kids were saying like Juuls were sold yesterday. I've moved on from that. Puff came out as a new popular thing that every kid's doing now, and I hopped on, and some of these new bars have the best flavoring and have the most nicotine. So some of these kids do know that these things have nicotine and they don't care. I mean, they're only looking at life at short periods of time, and don't see like the long-term, or don't appreciate the long-term consequences. Where do we start with our youth? We got to educate them. And that's what the intention, hopefully one of the purposes of talks like this are, which is to educate not only kids themselves, but their parents as well, and school administrators, teachers, counselors, psychologists, therapists. All of us need education when it comes to these types of things, to let the kids know what the dangers are of vaping, assessing use and addiction with different types of surveys, providing accurate information about the risk. You don't want to blow things out of proportion and then run scare tactics on these kids. They're really crafty. They can go look things up online, and they can call out BS when it's necessary. So you don't want to bring up things that aren't legitimate and evidence-based. We want to understand why they're vaping and then suggest different alternatives. You want to seek treatment for nicotine dependence, and we're going to talk. Give me 1 second. Switch out my. Okay, I'm assuming you guys can still hear me. Okay, seeking treatment for nicotine dependence early on, and medications or nicotine replacement therapy, along with counseling to help addicted young users to quit vaping. Just want to make sure you guys can hear me. Okay, so ACAP is the American Academy of Child and Adolescent Psychiatry. The risk factors that they came up with, this is one of the world premier psychiatric organizations. They came up with the different risk factors, including things like marketing, peer modeling, access to acquaintances, and parental use can be a risk factor as well. If you're using nicotine as a parent, there's a much higher chance that your kid's going to be using that as well. Nicotine exposure during adolescence is also associated with behavioral and neurochemical changes, as we discussed prior. Kids who are totally naive to tobacco are now initiating nicotine exposure with e-cigs and not cigarettes compared to their parents. And that overall, kids in our society perceive these devices as less hazardous, and they're actually not. In some ways, they're more hazardous. The CDC has also reported there's been an increase in exposure to poison control centers because of kids overdosing on nicotine. So ACAP recommends supporting FDA regulation, which has already occurred. It's, in my opinion, it's still not where it needs to be, but it's a step in the right direction. Supporting utilization of empirically tested and evidence-based treatments to achieve tobacco cessation outcomes. Advocates for vigorous education, which again, we're trying to do in these schools and different districts as well. Identifying these addictions early and intervening and early as well. And restricting e-cigarette advertisements on television, print media, and the internet, like similar to other tobacco products. The kids who are at most risk for cigarette use or e-cig use are parents, siblings, friends who use, those who exhibit characteristics of trying to act hard or tough or acting more grown up, those who outrightly deny the harmful effects of tobacco, those who have fewer coping skills and smoke to alleviate stress, kids who have poor self-esteem and depression, have poor academic performance, those who have issues with body dysmorphia, eating disorders are more likely to self-medicate with nicotine, especially the last one, the eating disorders. The reason why is because nicotine technically is a stimulant, and so it can curb appetite. And I've had several eating disorder patients who we found out later were using nicotine specifically to curb their appetite. The 6 A's are a simple 6-step approach to help guide clinicians when it comes to smoking cessation, how to approach kids. You want to anticipate the risk of initiating tobacco or e-cigarette use for non-smokers, meaning like some patients aren't going to reveal this unless you ask directly. And sometimes clinicians will ask about different substances, but they won't ask about things like nicotine and caffeine, which again are stimulants that can definitely exacerbate things like anxiety, mood disorders, sleep, appetite, so on and so forth. You want to ask patients whether they smoke, vape, or use other nicotine products. You know, advise them to quit and advise them on the risk of vaping. You want to assess their readiness, meaning you want to ask them if they're like in a pre-contemplative state of change or a contemplative state of change, meaning like the analogy for that is like a patient who comes into a doctor's office and asks the doctor, like, you know, doc, you're right. You've been telling me for years I need to quit, but you know, I do need to quit, but I'm not ready yet. And that would be the pre-contemplative state of change. When the patient comes in and says, "Doc, I'm done with tobacco, I'm done with nicotine, here's my start date, let's do this, like help me get off the stuff." That means they're in the contemplative state of change and they're ready to quit. And that's usually when patients respond the best to things like nicotine replacement therapy. You also want to assist them with their cessation effort, including pharmacotherapy. There are medications that can help with this as well. And then you also want to arrange for follow-ups to make sure that you're having routine contact and follow-ups, just to make sure that you're holding these kids accountable. Behavioral support includes things like smoking bans, parental smoking cessation, adolescent smoking cessation programs. So for some teens, we get quantitative THC levels, meaning like a numeric value of the 3 active metabolites of THC. And we can trace that over time. I have some kids who will push back and be like, "Well, I smoked recently, so it's going to test positive on a drug screen." And then my reply is, "Well, we can just do serial levels over time and see where you're at." And hopefully that was like a once in a blue moon situation. There's web-based and self-help programs too. These are some programs you can look up online. There's My Life, My Quit, Smoke Free Teen. Truth is another one. The Center for Young Women's Health is another website that parents and families can look up for different web-based and self-help programs. Schools have designed special punishments, sometimes including suspending or expelling students caught vaping. There's also vaping detection devices in bathrooms now, launching anti-vaping campaigns and even forming student committees that can help have kids help each other when it comes to even not going down that path or getting off of these substances. And then even incorporating anti-vaping into driver's education, which would be really beneficial because most of these kids are going into driving education, different driving schools. NRT stands for nicotine replacement therapy. Overall, it's evidence-based, meaning it's preferred over medications. Medications are evidence-based too, but typically NRT is a better treatment and longer lasting results. Those include things like the patch, gums, inhaler, lozenges, nasal sprays, for whatever reason, don't work as well with teens. Nowadays, we even have like these things called zip pouches, or Zin pouches, excuse me, where you can park the tobacco in a little pouch, and like that's usually good for patients or can be helpful for patients who are using chewing tobacco. And now they even have nicotine coated toothpicks that can help get some nicotine in your system to help with some of the withdrawals. A prescription is required under the age of 18 for a handful of these modalities. Parents do need to get permission from a physician to start nicotine replacement therapy. The reason why is because technically kids aren't allowed to purchase nicotine. And so if a parent's getting a doctor's advice and doctor's approval to go ahead and start NRT, then that's not a problem. But I have had a case where a parent did get CPS called to their house because the clinician wasn't aware that they had discussed this with a physician before. So that's something that I think parents should be aware of to prevent any undue distress. You want to start lower starting doses for smaller patients, those that weigh less than 45 kilos, and those who smoke less than one half pack a day. But the specifics you can discuss with your physician. Wellbutrin and Chantix is actually off the market now for different reasons, but there is no FDA-approved pharmacotherapy, meaning like medications for kids under the age of 18, although there's a lot of things that as a child psychiatrist I have to do outside of FDA purview. So that doesn't stop me from prescribing some of these substances, especially something like Wellbutrin. But antidepressants can have an increased risk of suicidality that actually could be, when we're talking about treating not just nicotine addiction, but also mood and anxiety disorders. Every now and then you can target multiple symptoms, multiple disorders with, like, for instance, like take out multiple birds with one stone. Like when it comes to like treating not only nicotine, but also some other disorders with like an agent like Wellbutrin. Occasionally you can knock out multiple symptoms at once, which is obviously a positive. But any of these medications are going to have potential side effects, and these things need to be discussed with your pediatrician or your whichever physician you're seeing for this issue. Wanted to segue into Aspire. Aspire is our program that Prina is an amazing manager. She's been running this program like an amazing captain for 5 years now. I'm super proud to be part of this program. I know Prina is as well. all of our clinicians are, because it's evidence-based and not only is it evidence-based to work, we get positive feedback constantly from families, not just the parents, but the kids themselves. And the program has been beneficial. So that's what keeps us going as clinicians. It's like music to our ears. It's worth more than any amount of money on the planet when you're able to make a difference in a kid's life, and not only the kid's lives, but an entire family unit. It's super rewarding for me as a physician to be part of a program where I'm not just relying on medications. Real briefly, this program is an 8-week program. It's after school. It's Monday, Tuesday, Thursday, Friday between 3:30 and 6:30. Again, the program is evidence-based. It uses a specific type of therapy called dialectical behavioral therapy that is evidence-based. Long story short, it's to help with resiliency training and to help develop coping skills and improve, or if you already have some coping skills, help to practice those coping skills, because practice does make close to perfect. And what we're trying to do, hopefully, is in collaboration with different school districts, is to get some of this DBT curriculum incorporated into health curriculum, because we think every kid, every human on this planet could benefit from coping skills and resiliency training. At the program, we work collaboratively with parents, teens, and our treatment team to address behavioral issues and even future needs for aftercare. Any after-school obligation is put on hold until the teen completes the program. And that's because health and mental health are one and the same. They take priority over different types of after-school obligations. Parents are come in right now. We're doing Zoom with parents, but kids are in person, and we never shut down the entire time during COVID. We're one of the only programs I know of that remained open the entire time, didn't shut down for a single day. And I'm happy and I'm proud of that, because these kids needed the socialization. They needed this program more than ever. And I was really happy that the administration and the higher ups, the executives above, knew that we couldn't shut down. This is like the absolute worst timing, in our opinion, to shut down, and we never did. So that was really nice. The other thing that's really beneficial about our program at HOAG that's different than other programs is that we do have a really strong philanthropic arm, the HOAG Foundation. Somewhere, last I checked, $900 million, something to that effect. Not all of that money, unfortunately, is allocated to Aspire, but we do have scholarship funding. And because we've had so much good feedback and the program's blown up in a positive way, where we're constantly getting more donations, because the program's consequential and it's making a real difference. And so for families who can't afford the program, or insurance doesn't cover their program for whatever reason, if they qualify financially, they could get the entire program covered. The other great part about Aspire is that we were the first program in Southern California with WASC accreditation. Every school district that's public in on the Western states, meaning all the entire West Coast, has to get WASC accredited. And so we're technically a legitimate, real after-school program where kids are going to get 5 hours of elective credit if they graduate from the program. And I believe we have that connection now, in the collaboration now with like 7 different school districts. So pretty much most kids that come in our program, even private school kids, are getting some credit for graduating our program. The last thing I was going to say is for kids who for whatever reason the insurance companies drop coverage, that HOAG Foundation comes in and every kid is able to graduate the program, because we have 4 distinct modules over the 8 weeks, and we want each kid to make sure that they get the entire curriculum, not just piecemeal. And so that's another huge benefit for being part of HOAG, that we do have that foundation backing, and it helps big time. Right now, I wanted to mention, last thing is that we're in Newport Beach and Irvine. At this moment in time, we have 2 teen programs, the Aspire programs in Newport and in Irvine, at HOAG Newport Hospital and Irvine Hospital. We also have a young adult program, ages 18 to 26. And in the future, very near future, we're talking about opening up another young adult program at Newport Beach. And the next step after that is to open up a younger track, like 9 to 12-year-olds, because unfortunately there's been a stratospheric rise in depression, anxiety, and even suicidality with these younger kids. So it's really unfortunate, but I'm really thankful to be part of an organization that takes mental health so seriously. I'm also thankful to be here today with the school district that also takes mental health seriously as well, because it's something that's been long overdue. And now that programs like these hospital systems and school districts are working together, only positives can come out of these collaborations. So I really appreciate everybody's time today, and we can open up to questions now.
Sina, and welcome again, Prerna. I'll take questions in the Q&A portion. So if there are people watching today that have questions, just put them in the tab for Q&A and we can go through them. Dr. Sina did sort of mention one of the questions that I had, which is what changes or what have you noticed? What trends have you seen the last 2.5 years for COVID? And are there anything specific that parents should be watching out for?
In reference to overall, like mental health, or in reference to drug use?
Overall or drug use. So it could be both.
It's a great question. I have an entire presentation on this question, but I'll delve into it briefly. If anyone, hopefully in the audience, you guys heard that the Surgeon General, our current Surgeon General, a few months ago released a report. It was like 40+ pages, and it goes into specific detail and specifics about how these kids have been, unfortunately, very negatively affected by COVID. Not just the social isolation, the increased screen time, the increased self-medication because they're isolated. There's nothing normal about kids, especially kids, but not all of us, but especially children and teenagers being at home, being behind these screens, trying to learn as much information as they can, especially those, imagine, with ADHD. They already have focus issues and they're trying to pay attention to a teacher through a screen. I feel like these kids are behind, the entire planet is behind maybe a year or two educationally. And then that goes hand in hand with maturation in different ways. And so we've seen at our program and in my own private practice, a huge increase in demand of kids and young adults that need to be seen. Significant increase in suicidality, significant increase in anxiety disorders, significant increase in mood disorders. Back to that Surgeon General report, there was a 51% increase in ER visits because of suicide attempts for teenage girls. 51% in 2 years. If that's not an emergency, like nothing is. And we're talking about the most vulnerable population in our country. And so it's something that one statistic alone is terrifying. And so at the Aspire program, Prerna, you can attest to this too, we're seeing it firsthand. And our wait list right now is unfortunately months on end. And it's because of what we're talking about. Like, there's no doubt these kids were affected negatively, and they're going to be affected negatively for years to come. Like, I don't see, not that there's no light at the end of the tunnel, but we're going to be in this for the long haul. It's not going away like tomorrow. And even though like things are thankfully quieting down with the COVID numbers, the long-term consequences of what happened over the last couple of years are going to be with us. And that's something that, like, we're happy to be part of, but I'm happy, and I know Prerna is too, and our entire institution is thrilled to be in a situation, frontline workers, to help out kids with this. But we need way more programs. We need way more clinicians. We just need more support overall, because the demand supply curve is completely skewed. Right. And I'm sure parents in the audience can appreciate that, trying to get doctor's appointments and therapy appointments. It's really hard right now.
Yeah, and we even noticed the same thing internally in our school district, and we devoted millions of dollars hiring more counselors just to decrease the level of students to counselor ratio. But you're right, it's not enough. We're at, I think, 450 students to 1, which is probably one of the lowest ratios in the state, but it's not anywhere to what we could be if we had more funding.
Yeah.
So I guess that the next question from a parent is, how do you encourage children to attend Aspire program if they're currently resistant to group therapy?
Prerna, did you want to answer this one? I can follow up too.
Yeah, that's a great question. We tend to encounter a lot of these situations where teens either are resistant or they tend to sort of have reservations when it comes to attending a group program. So what we typically recommend is that even if you would like to bring the teen in for a tour, just so they can come speak to us, that can sometimes also help sort of break the ice a little bit when it comes to answering their questions. I think for a lot of teens as well, and kind of what's unique about our program is that we're not very process heavy, so they're not having to sit there and process their feelings. It's all based on coping skills. So typically when they meet with the facilitators and they get a better understanding of that, we have seen some teens that typically tend to be more open to attend the program. It can be a challenge if teens are not open and receptive, especially when they hear the words outpatient program and group therapy. because a lot of teens don't feel comfortable opening up and sharing with other teens. But what we've noticed is either they can come in for a tour, or one of our facilitators is also happy to speak with the teen on the phone, just to see if we can get them to ask any questions and sort of ease some of their fears that they might have as well.
Yeah. Also, sometimes learning them, like with a carrot, that you're going to get 5 hours of elective credit if you go through this program, and maybe even can graduate a little bit sooner, or senior year you can leave school earlier and whatnot, and like a half days and stuff like that. And sometimes that can be appealing for some teens as well. Sometimes, not that I want parents to manipulate their kids or like lure them into these types of programs, but sometimes if there's something they really want, or let's say they want to go on a vacation or a trip somewhere, or any particular item they want, or concert, something like that, sometimes you can use that positive reinforcement as a reward if they're able to complete the program. And we've had some parents utilize that strategy as well.
Okay. And then what do you know, or what have you seen about if there's an increase in kids using, I guess, triple C or other over-the-counter medications? Are you seeing that as well?
I mean, I can't tell you definitively if there's been an increase, but that's been prevalent throughout, especially kids. If they don't have access to, let's say, friends or parents who have access to like hard drugs, they're going to try to self-medicate in different ways. And so I've had a handful of kids that use triple Cs. Thankfully, it's not that common. But we've had other kids who even self-medicate with things they wouldn't even think about, like Benadryl and other substances that are like more sedating. In that situation, you think they're not per se trying to get high. They're trying to snow themselves. They're trying to numb themselves to like what they're feeling, and they're willing to do whatever it takes to just not feel how they're feeling at that exact moment in time. So it's something that when you go into a pharmacy, I hope these days they're being a little bit more vigilant about like either the tech behind the desk about like what age group is purchasing these things, but sometimes depending on if they're able to go to the right pharmacist or pharmacy at the right time, they may be able to get some things that they wouldn't otherwise.
Okay. And then another parent asked, their child has developed OCD or anxieties over the last 2 years. So would a program like Aspire help them?
For sure. We treat all different types of anxiety disorders, including OCD, generalized anxiety, panic disorder, social anxiety. We treat different types of mood disorders. We even treat things like ADHD. ADHD is actually in some ways underdiagnosed and kind of gets convoluted with different disorders. You can imagine a kid who's high IQ but not performing well on paper. Over time, that can lead to an erosion of self-esteem and confidence and depression, anxiety. That's just one little example of things that we can treat. We also have had several kids that are on the spectrum, typically more high functioning. And these days, because of the increase, we've had a lot of kids with transgender issues and gender dysphoria as well. So we pretty much try to treat as much as we can. There's a few things that we can't treat directly, or we try not to, and we refer out. Some of those things are things like eating disorders. For mild eating disorder, or if there's some disordered eating, that's something that we can potentially treat. But if it's a full-blown anorexia, there's tons of weight loss, functional impairment, where these kids typically would need higher levels of care than what we can provide. And then for substance use disorders, if the primary issue is substance use, then that's when we refer out to different types of programs that specialize in that. But if the kid has dabbled or is currently dabbling with different types of drugs and alcohol, if they're willing to cut down or be sober, at least while they're in the program, that's something that we can potentially help out with. But if they're not able to, then we refer out to either, again, primary substance use programs or dual diagnosis programs that specialize in both mental health issues and substance issues at the same time.
Yeah.
Prina, did you want to add to that?
Yeah, and I think what's also been extremely effective is we use, like Dr. Sina had mentioned, we use dialectical behavioral therapy, which is known to be probably one of the most statistically effective therapeutic modalities currently being utilized in mental health, because it can help such a wide variety of different diagnoses that's rooted sort of in the aspect of the coping skills that the teens learn. So I think that's something that a lot of parents, when you're researching something, is something I would encourage them to look at is, cognitive behavioral therapy, dialectical behavioral therapy. Those are some of the modalities that currently seem to be the most effective, especially with COVID sort of exacerbating the symptoms that much more too.
Okay. And then a parent writes that they have a child who does have ADHD and is not using any illicit substances, but is cutting. What would be the most effective way to help them?
Yeah, that's a great question. And oftentimes what we want to look at too is if it's just ADHD, or if there's also some depression associated with it. Sometimes teens can also be extremely impulsive. And that also seems to tell me that there could be a lack of coping skills as well, that teens don't intentionally want to hurt themselves. It's the only outlet that they understand of. And that's the only thing that they know what to do with, is to unfortunately take part in maladaptive coping skills. That's what we call it in the mental health world. And so that's why it's important to look at, is it just ADHD? Is it depression that's making them a little bit more impulsive to sort of numb the depression? And I think that's sort of the variety of aspects we have to look at when we're treating a teen. Sometimes there's layers to a situation and to a diagnosis or similar challenges that a teen might have. So it's not necessarily just one thing. It could be several factors that are associated with it too.
Yeah, I agree with that. And one thing I want to remind parents and everyone is that like ADHD, OCD, anxiety, tic disorders, Tourette's, autism, these all come from the same areas of the brain. And so there can be a lot of overlap. Imagine like a Venn diagram that overlaps all on top of each other. It's not surprising that some kids with ADHD are going to have anxiety and OCD type symptoms. When a child has ADHD that's diagnosed and they're also cutting, higher chance than not, there's either an anxiety and or depressive component to that as well. Whether it's impulsive or not, that's something that we can delineate over time. But if a kid is doing that, that's something that obviously needs to be addressed and needs to be taken seriously, because it's at minimum, at absolute minimum, it's a cry for help. At maximum, it could be a potential suicide attempt. So it's something that some of these kids and adults will try to substitute that emotional pain with physical pain. And one thing that they don't realize, most of them don't realize, is until things get worse, is that just like any drug, this gets less and less effective over time. Like your body and your mind develop tolerance to that maladaptive coping mechanism, and you got to up the ante. And then beyond that, the last thing I was mentioning is some people aren't aware that some scars don't go away. Like with keloid scars and whatnot, these scars can be like 2-3 inches off your body, where you have to go see a plastic surgeon to get what's called a keloidectomy. And then 50% of the time with keloidectomies, the scar comes back again. And so that can be disfiguring, potentially lifelong disfigurement. That's going to impact these kids and even be a reminder in the future that I had this issue when I was younger and whatnot. So we want to try to nip these symptoms in the bud while these kids are still young before it becomes a bigger issue than it needs to be.
And I just want to share too that just for parents to be aware, COVID obviously has brought a ton of challenges, but we're seeing a substantial increase in suicidal ideations from teens and children as young as 10. And we get phone calls at Aspire for parents that are looking for referrals for their 8-year-olds, 9-year-olds who are having suicidal thoughts or ideas. And so I just want to encourage parents that if your teen is expressing anything like this, to please take it seriously and to reach out for help. You can always contact our program. We're more than happy to give you information or give you referrals. But in general, any mental health provider, it's important to reach out and make contact, because the last 2 years have been extremely unfortunate when it comes to the mental health acuity that has increased, especially for our teen population. I mean, we're seeing it in the media as well with the most recent news of the 3 athletes from college who unfortunately died by suicide as well. So it's definitely that is now becoming a major epidemic at this point too.
Yeah, I was gonna piggyback on that real quick. If your child's expressing any suicidal ideation, like meaning active thoughts meaning intention or plan, not just like, oh, I wish I wasn't alive, I wish I wouldn't wake up. Those things are obviously red flags too, need to be taken seriously as well. But if a child's expressing an intention or plan to harm themselves, that's analogous to them having a heart attack or them having a bone sticking out of the leg and parents ignore it. And unfortunately, a bone sticking out of the leg and a heart attack, these things are few and far between. Suicide completion is actually it's a much higher rate. So these things need to be taken seriously. And I would, if a child expressing that, you either call 911, you go to the ER, or you call the CAT team. The CAT team is a psychiatric mobile team that's county based, And we can give you guys that phone number if you need it, but that's a great phone number for parents to have, especially if your kid is struggling. And they're a county-based team that can come to your home. They're also the same team that comes to the hospital typically in the ER. And so you don't have to go sit in the ER for 5, 10, 24 hours, sometimes even longer, waiting for that team to show up. You can do that at home. Although I would say if the kid is in imminent danger, calling the police or taking to the ER might be a safer strategy. So that's something I'd want to throw out there as well.
Okay. And then what do you say to parents? Just 2 more quick questions. What do you say to parents who are confronted with wait lists looking for resources for their children?
Yeah, this has been such a challenge for parents, and we're encountering this at the Aspire program too, when it comes to referring out at discharge as well, or even during the program. What I'm encouraging parents to do is first go through your insurance provider and see if they can send you a list of therapists for you to be able to call and make contact. The other great site that you can use is psychologytoday.com. They can find you a list of therapists, and typically it'll say on each therapist profile if they're currently accepting clients or not. I think this has been probably the biggest challenge for parents, is to find therapists that have availability, which I can completely understand with. But I would say start with those 2 platforms first. We also work with a handful of providers as well that we vet out, because we have a lot of clinicians that want to work with HOAG. And so sometimes we are able to also sort of tap into our pool of therapists that might have some availability that specialize with teens. So you're more than welcome to reach out to our program as well. And we can try to see if we can get you some referrals too. But Psychology Today is a great place to start as well.
Mm-hmm.
Okay. And then there is someone who did ask for the phone number for the CAT team, and I looked it up on Google and couldn't find it. But if you have it, we can share it.
Yeah, it's 714-517-6353.
Okay.
No, 714-517-6353.
But if necessary, calling 911, the sheriff's department or law enforcement, wherever you're at, could also dispatch the CAT team if needed.
For sure. And then a lot of times the CAT team, the police will stay outside just in case it's some type of emergency where they're required. But I would definitely make sure that if you do call 911, you let them know like what the issue is, that your kid's not dangerous to others, and that it's more about you just making sure that they're safe and they need an assessment, so they don't come in like guns blazing or anything like that, which they wouldn't do anyways, but just to cover your bases. The one thing I was going to say too about the wait list situation is these wait lists actually move faster than people think, and people get disinterested or find different providers, different programs. So I would put my name down as many wait lists as possible. And then those actually move fast. Like even our program, we'll tell a family, or the next time that could pop up is maybe like 2 months, but then based on different factors, that changes to like a few weeks sometimes. So I wouldn't get discouraged as difficult as that can be.
Right. So don't walk away, put your name on the wait list, and then find other places to put your name on the wait list too. Okay.
Exactly.
And then the final question is how parents could contact Aspire.
Yeah, so we have 2 locations, Irvine or Newport, and I oversee, as a clinical manager, I oversee both. And then we have a team of 4 clinicians, 2 externs, and we have several trainees that will be starting with us as well. And so if you contact either one of our sites, you can go through our website, hoagaspire.org, and you'll be able to pull up our information on either location, and we'll be able to give you a call back. Typically, we'll return calls within 24 hours. If it's the weekend, we'll call back that Monday, and then we can go ahead and gather clinical information and then see if Aspire is the best fit. And again, if we're not the best fit, we're always more than happy to give you some referrals that might be a better fit for you too.
Mm-hmm.
Okay, and with that, Dr. Sina Safahieh, thank you so much for being here tonight with us.
Thank you.
We are so grateful for what you do in our community and for the support you've given us even before COVID. I know we'll be calling you out again. And Dr. Cena, you mentioned specifically just the trends of COVID and mental health, and that you have a presentation. So maybe that's something we can do in the next couple months.
Sounds good.
We really appreciate you being here, and we wish you all a very good evening. Thank you.
You too. Thank you.
Thank you so much. Thanks for having us.